Hello and welcome to Para sa Puso, a webinar for American Heart Month on Filipino heart health. My name is Julieta Velasquez and I am a student fellow with FilPro Tayo, which seeks to empower Filipino Americans with data, culturally relevant insights, and leadership development. Assisting me today are fellow scholars Megan Dalalo, Geneva Diemen, and our live translator, Francis Rodriguez.
Thank you all for joining us to hear about a variety of heart health topics, from epidemiology and risk factors in women, to hypertension, to how heart health intersects with the Filipino diet. There will be an open Q&A, so please save your questions until the end. And as a quick disclaimer, this webinar is for educational purposes and not for medical advice. Should you have any medical questions, please consult your primary care physician.
We are thrilled to welcome a very special panel of speakers. Dr. Annabelle Volgman is Professor of Excellence in Clinical Cardiology at Rush University Medical Center and Vice Chair for Academic Affairs in the Division of Cardiology. She completed her MD at Columbia University, residency at University of Chicago, and completed fellowships in cardiology and clinical electrophysiology at Northwestern University Memorial Hospital. She is co-founder and medical director of the Rush Heart Center for Women and has been a leader in the American Heart Association's Go Red for Women campaign since its inception. Go Red for Women aims to inform women about cardiovascular disease risk and actions they can take to protect their health. Dr. Volgman has dedicated her career to helping women and their families lead healthier lives through prevention and treatment of cardiovascular disease.
Our second speaker, Dr. Julieta Gabiola, is a clinical professor of medicine at Stanford Medicine. She completed her MD at Rush University Medical School and completed her internal medicine residency at Stanford. She is a faculty fellow at the Stanford Center for Innovation in Global Health and has been a foundational faculty member of Educators for Care, an initiative that fosters compassion, advocacy, responsibility, and empathy in medicine. Her passion for improving health outcomes and access to care extends to the global scale. Dr. Gabiola is the founder of the nonprofit organization ABCs for Global Health, which works to provide access and continuity of treatment with education, prevention and research to help improve outcomes of cardiovascular and chronic diseases for Filipinos in the Philippines and in the US.
And our third speaker, Dr. Kyla Lara-Breitinger, is a cardiologist practicing at Mayo Clinic, where she is co-director of the Cardiometabolic Clinic. She completed her MD at Rush Medical College, clinical residency at Icahn School of Medicine at Mount Sinai, and completed fellowships in cardiovascular disease, advanced echocardiography, and preventative cardiology at the Mayo Clinic College of Medicine. Let's give a warm welcome to these incredible speakers. And Dr. Volgman, please take it away.
Thank you so much for inviting me, Rihanna, and everyone else at FilPro. I'm so happy to be here. I'm just trying to do things, two things at once, trying to share my screen, and there we go, and speak. So I was asked to, thank you for that wonderful introduction, and I'm so happy to share this webinar with two Rush Medical College alumna. Both of them went to Rush Medical College, and I was so fortunate to have met Dr. Kyla Lara before she was Breitinger, and she was a fourth-year medical student, and we bonded ever since. And Julieta and I, we met at Stanford, and we've been friends ever since, and doing things for Filipinos. I was asked to talk about cardiovascular health in Filipino women. So I'm going to just summarize something that we actually wrote together. But let's just give you, I'm sure all of you in this webinar know that cardiovascular deaths cardiovascular disease is the #1 cause of deaths for women in the United States. But they wanted me specifically to talk about Filipino women. So that will be the topic of this webinar. But cardiovascular disease kills more women than the next 5 causes of deaths combined, including chronic lung disease, lung cancer, and breast cancer. And unfortunately, more women are afraid of breast cancer, of getting breast cancer than getting cardiovascular disease, not knowing that cardiovascular disease is probably what's going to lead to their mortality more than breast cancer. But, you know, we have to respect everybody's ideas about health, and we definitely want to respect that and work with them on where they are in terms of what their concerns are. 1 in 3 women have some form of cardiovascular disease, and unfortunately, 1 in 4 will die. But these are statistics from 2015, which have not changed very much in the last few decades. I'm just going to give you a summary about the epidemiology of Filipino American women. If you look at the subgroups of Asian Americans in the United States, Filipino Americans and Asian Indians, so people from India or the South Asians, have the highest number of years of life lost because of ischemic heart disease. So this is strokes and heart attacks. This is how we lose a lot of a good life because of ischemic heart disease. So whether it's you have a heart attack or stroke can really affect your quality of life. Filipino Americans and Vietnamese Americans have the highest number of years life lost because of stroke, cerebrovascular disease. In terms of hemorrhagic stroke, and as you know, most hemorrhagic strokes are due to ischemic stroke. Most hemorrhagic strokes are due to a stroke that was from a blood clot that came from the heart or from the carotid arteries, the arteries in the neck. And that's higher among Filipino men and women compared to non-Hispanic white people. And in terms of Filipinos with diabetes, related cardiovascular proportional mortality. So the number of people who are dying from it compared to the number of Filipino Americans there are, it is the Filipino Americans have the highest proportional mortality. So it is really wreaking havoc on our health. So we really need to prevent diabetes by eating the right foods, which Dr. Lara-Breitinger is going to talk to us about, and then exercising. In terms of proportional mortality ratio, it's the highest in Filipino Americans, higher than that of the Asian Indian and non-Hispanic Blacks. So it's a really bad risk factor for Filipino Americans. Filipino Americans have the higher prevalence of comorbidities such as hypertension, diabetes, and high cholesterol compared to other Asian ethnic groups. So higher than South Asians, higher than Vietnamese, Japanese, Koreans, and Chinese. Filipino Americans had the lowest rate of adequate blood pressure control than other Asian subgroups and non-Hispanic whites, partly due to non-adherence to medication. And they also have a higher BMI in the Filipino American subgroup. I was really surprised when we were writing a review paper on this, that a lot of Filipino Americans, and in my own practice, a lot of Filipino Americans don't really want to start medication because they believe that God will help them lower their blood pressure, or they'll change the way they eat, and they never do. So they continue to just have high blood pressures, and it's really terrible. And Dr. Julieta Gabiola will talk more about hypertension during her talk. Filipino American women are at the highest risk for having all dyslipidemia subtypes, including high cholesterol, high LDL cholesterol, and low HDL and high triglycerides, compared to all non-Hispanic whites. This is similar to Asian, Indian, and Vietnamese women. So not a good thing for us either. Filipino Americans have the highest current smoking rate of Asian Americans at 12%. This is terrible. This is really something that we need to work hard on as medical professionals. This is twice the rate of Asian Indians and Chinese. And overall, the rates of depression and trauma are higher in Filipino Americans than in other Asian ethnic groups. Filipino Americans also had the higher prevalence of obesity compared to other Asian subgroups, with an increasing obesity trend over time. In terms of heart failure, which is a significant cause of hospital admissions, quality of life deterioration, and just longevity, it's significantly increasing in Filipino Americans and Filipino American women and men. Overall, Filipino Americans tend to be the youngest when they present with stroke compared to other Asian Americans and non-Hispanic whites. So overall, death rates in men versus women, unfortunately, women tend to have less heart attacks than men, but when they do have heart attacks, their mortality, according to these statistics 20 years ago, they have twice the risk of dying from that heart attack. And heart attacks is the leading cause of deaths among Filipinos, just like here in the United States. Women also tend to present differently. A lot of women don't say the word chest pain. They don't like to use pain when they're describing their sensation when they're having a heart attack in their chest. So nowadays, we just have to say that women tend to say there's something wrong in their chest. You don't have to have the word chest pains. But when you are ordering tests, you have to write chest pain because that's how insurance companies will pay for these tests. So I tell my patients, please use the word chest pain when you feel something different in your chest so that you can get the right EKG and the troponins when they're present with the emergency room. Because if you say, I feel like I'm having indigestion, that's what they'll think is what you're having. So please don't give them that idea that you're not having a heart attack by using the wrong words. You have to use the words that doctors and nurses understand in the emergency room. Just say, I'm having chest pains. I think I'm having a heart attack. I need an EKG and troponins, and you will get more attention. But I wanted to share with you that some women who present with heart attacks are just complaining of shortness of breath, fatigue, nausea, and other different symptoms. We need to know that all women are at risk, and this risk of heart disease increases after menopause. I'm not going to go through all of these facts because I don't have a lot of time, but I just wanted to show you a picture of why anything you do with your cholesterol, your blood pressure, will affect the heart and the brain the same way. So heart attacks and strokes come hand in hand, and then the kidneys are also affected by cardiovascular disease, and ischemic forms of peripheral artery disease can also affect, and if somebody has diabetes, that increases the risk of amputations of these limbs. So very important to know your risk factors, know your numbers. In terms of cholesterol, you need to know what your LDL is, what your triglycerides, and you need to know what your numbers are also with your weight, because once you have a BMI of greater than 30, you are considered obese, and that obesity really increases the risk of having cardiovascular events. So unfortunately, a lot of Filipino American women have that diagnosis of obesity. Diabetes is a terrible disease, not just a risk factor, because once you have diabetes, you've already had spent years of a lot of comorbidities. So we consider it a coronary heart disease equivalent. Once you've been diagnosed with diabetes, your risk of having a heart attack is the same as somebody who's already had a heart attack. And unfortunately for women, once a woman is diagnosed with diabetes, their risk of coronary heart disease is much higher than a man's risk of heart attacks if you're diabetic. So it's unfortunately a really bad risk factor for women. Smoking, as I said, is terrible for heart disease. Unfortunately, 18.5% of American women aged 18 and older is smoking, and it's increasing in adolescents and women aged 65 and older. We really need to emphasize this risk. Physical inactivity is very common among women, and it really increases the risk of heart disease, stroke, obesity, diabetes, all of those things. So what can we do to protect ourselves from these unfortunate events? We need to know our risk factors. We need to know our numbers. You need to stay healthy. See your doctor regularly. Make sure you're not smoking. Engage in healthy lifestyle, either diet and exercise, and especially your stress level, because that can really cause problems with the heart as well. If you're young and thinking of doing a pregnancy or being pregnant, make sure if you have any of those risk factors, make sure you talk to your doctor, see a cardiologist, because they can really affect your risk during your pregnancy, after your pregnancy, of developing all kinds of problems during your pregnancy and also after your pregnancy. So make sure that you are getting screened for your blood pressure. You want a blood pressure less than 120/80. Make sure you know what your cholesterol is. Make sure you know what your body mass index is and your sugar. And also we need to discuss smoking and physical activity and diet with our doctors. We go one step above and beyond knowing those risks. One way you can know if you are developing atherosclerosis, which can lead to heart attacks and strokes, we are giving a test called the calcium score, and it costs, you don't even need a prescription for it. You can just call at Rush. It's $49. And I know you're not all here from Chicago, but most hospitals will do this test for you at a very low cost. And it's probably the one way you can know if you're developing plaque already, and not just a number that you can get from your doctor, but it's your heart, and you will be much more motivated to do something if you have you've already developing plaque. Thank you so much.
Thank you, Dr. Santos-Volgman, for sharing information on screenings, for speaking on the risk factors and statistics, the importance of mentioning chest pain, and really emphasizing the importance of awareness and prevention, which really is a driving force of why we are here today. Next up, we will have Dr. Gabiola share her insights.
You're muted, Julieta.
Hi, thank you for having me, and thank you, Tayo, for having this webinar. I love this because I think part of our responsibility as physicians is to improve that messaging to the public, right? And to the Filipino American community, especially, and to Filipinos in general all over the world. I think it's amazing that Filipinos are one of the population with highest cardiovascular risk factors, as what Dr. Annabelle Santos-Volgman had outlined. Not only that, it's, we also don't control all of those risk factors. In medicine today, we have a lot of pharmacological intervention available. It's easy to diagnose, for example, hypertension and heart disease. But why are we not improving the care and awareness and treatment for hypertension? There's an improvement in management of heart attack, but we still are losing a lot of people. And I think as doctors, I think part of it that's missing is really the way we message our patients. And I think a webinar like this is so important. And especially if you have this interpretation, thank you, Francis, for doing it and making it really available and friendly to the community. So I would try to speak in a layman's term and not really more scientific, because it's really to reach people. The statistics that were mentioned by Dr. Volgman are not just in Filipino Americans, and they're so common in the Philippines. And what's so unfortunate are the complications of heart attack, stroke, and all these cardiovascular events are happening much earlier among Filipinos, like a decade earlier. If you walk around in the Philippines, for example, there's an explosion of kidney dialysis centers, right? This is in a population of people who hardly go to doctors because there's not much access to care. People go to the hospital when they're already dying, which is so unfortunate. At least here in the United States, we have insurance, we have medications, but we still don't improve the outcome of hypertension and diabetes and all these cardiovascular diseases. So when we talk about comorbidity, like what Dr. Volgman had mentioned, comorbidities is the presence of other diseases that puts you at risk. And if you look at Filipinos in general, we have obesity, we have hyperlipidemia, we have smoking, we have stress, we have obesity. So you name it, it's there. So it's not just treating one disease, it's really treatment of everything that a patient has. So I want people to be aware of that. And then talk to your relatives, talk to your neighbors, and really form a coalition and of people with kindred spirits to really motivate each one to be doing all this physical activity, to stop smoking, cut back on alcohol, maybe stress reduction, and eating healthy food with Dr. Kyla Breitinger will be talking about later. So when I look at hypertension, why am I interested in hypertension? Why hypertension? Well, as I mentioned, it's a number one killer, and it's a silent killer because there's no symptoms, right? People in general say, well, I feel good, so why do I have to go to the doctor? And then when you see them, the blood pressure is 200 over 100. So in the Philippines, when we do medical missions, my students and my faculty from Stanford will go around and would like to send all these people to the emergency room because they have hypertensive crisis, right? Mainly because their blood pressure, they're walking around with blood pressure of 210 over 110 with no symptoms until that heart attack happens or that stroke happens. And that's really criminal because we could do something about it to prevent it even. And if you have it, we have something to treat it. But we're not doing such a great job. We're not controlling it. A lot less people are even aware that they have high blood pressure. So I think it's really great to do screening, to take people's blood pressure from age 18 and above, and at least the people at risk, for example, maybe even frequently. So that's one. And then the other is, why am I interested in hypertension? It's so easy to diagnose, as I mentioned, and it's a number one killer. And then it's preventable. And as I mentioned, once you diagnose it, it's treatable. We have a lot of medications now for hypertension, not just that medication, but lifestyle intervention. So hypertension is a lifestyle disease. What do I mean when I say lifestyle disease? Well, it is something that you could get better with stress reduction, with eating healthy, exercising, decreasing your weight, cutting back on alcohol and smoking. So that's what I mean with lifestyle modification, and maybe sleep better, right? Go for sleep management. Before you get into the drug regimen. And then next slide, please. So when we talk about blood pressure, this changed dramatically the last decade in terms of what we define as high blood pressure. If you walk around, people seem to think that 140, 150 of blood pressure is okay. You know, you talk to a lot of Filipinos, oh, my blood pressure is good. It's 150 over 80, you know. That's not good enough now. I think we have to have people really make sure that they get as close to 120 if they can, without too much side effects from medications and from other comorbidities. So I think to get lower as you could get, the better you are. So I would stress on that. And the 140 is not any good anymore. Before, 140 and above was basically like stage 1 hypertension. Now stage 1 hypertension is really 120 to 130 to 139. So those have changed because I think the rationale is if you get people early, you prevent the evolution of endothelial dysfunction or dysfunction in your blood vessels. Next slide, please. In the Philippines, we see, as I mentioned earlier, stroke, heart attack, heart failure. And in the United States, we see that also a lot earlier among Filipinos. In the Philippines, it's so it's not unusual that you'll see people on dialysis and who had stroke at age 45. That's really unacceptable. We have to do better. So I think, and then once they develop, of course, kidney failure, the cost of dialysis is so astronomical. And the cost of taking care of our family who had stroke is also in order of magnitude, so much that people really can't afford it. And in the Philippines, for example, because we don't have insurance, we don't have money to cover medications, cost of dialysis, people really sell their properties. They sell their caravans, they sell their house, they sell everything that they have because they couldn't stand mother or their sister to really just do nothing. So you'll spend everything that you have to really take care of your family. So that's also unacceptable. So now, not only all of this sexual dysfunction, visual loss, heart attack, and kidney, now it's also cognitive dysfunction, early dementia. That's so common now in terms of the part of the end organ damage of hypertension and other cardiovascular diseases. So the better you control your cardiovascular risk factors, the better your prospect of not developing dementia. So that's cool. Next slide, please. So in the Philippines, because we don't have much access, we have this sort of an activism to really provide access to care to patients before they have to go to the emergency room for heart attack and stroke. So we have this medical mobile clinic going around the different communities. We have 18 barangays now in Pampanga. My vision is to have every province have their own medical mobile clinic. And then on top of that, we also have the telemedicine with the use of this gadget. As you see here on this slide, the top slide to the right, we have this telemedicine. We have stethoscope on that. We have blood pressure machine, blood sugar machine, 1-lead EKG, pulse oximeter, a thermometer, and we have a stethoscope also. And in that kit now, we also have urine to check for albumin, etc. So this is really reaching out there, expanding our reach without having to see a doctor. The only thing that we need is a stable internet. So that's also being launched in the Philippines. Actually, that's what that was launched by my medical students from Stanford 3 years before the pandemic. We don't even have those kits at Stanford, to tell you honestly, but we have them in the Philippines. So that's how advanced we are. We have electronic medical record in those mobile clinic, and everything is so computerized. So we have rich data, like 5 year of data, that's real world data. Nothing like that in the Philippines and the communities. Next slide, please. And this is what we do in the communities. We have the medical mobile clinic going around in many neighborhoods. We do not only treatment of acute and chronic diseases, but we also do prevention, education, and research. And I think I'd like you to support it. Our organization is ABCs for Global Health. And now we partner with ABS-CBN, so to basically improve our messaging and our networking with people all over the world, Filipinos all over the world, and also in the Philippines. Thank you for this opportunity. I'll, back to you, Rihanna.
Thank you, Dr. Gabiola. It really is a pleasure to hear about, your extensive work making healthcare and chronic disease management more accessible to the Filipino community. And our last speaker for tonight is, before we open the floor to a Q&A, will be Dr. Lara-Breitinger.
Kyla, you're muted, just in case you didn't know.
I didn't know, thank you. All right, so I will respect everyone's time. Let me just switch my presenter view. So thank you so much for the invitation. Basically, I'll just quickly share a case example of a 46-year-old man who came into the clinic with acute chest pain. So he had the typical risk factors that both Dr. Volgman and Gabiola discussed, and basically in addition also had diabetes. And so, for those of you who don't know EKGs, this is a pretty classic presentation of an inferior STEMI or an ST elevation myocardial infarction. So you see here quite the abnormality in these leads owing to this part of the heart. And this is a cath. When you send someone to the cath lab, or if you had a loved one or a patient who's been to the cath lab with a big heart attack and they're opening a blockage and putting a stent in, this is one of the catheters that goes through the wrist artery or your radial artery, and it is injecting the right coronary artery. And you see that there's an absence of flow here at the mid RCA or right coronary artery. So it is an ST elevation STEMI. And so this patient underwent thrombectomy and also PCI. So that is his flow afterwards. And so a very slow flow here coming back in. And so just to piggyback off of what was said already, having a healthy diet, just in terms of the Asian BMI classification, just a shout out that Asians, are considered overweight and obese at lower cutoffs than the conventional BMI category. So obesity actually starts at a BMI of 25, which conventionally is considered overweight up until 29.9, but not for the Asian BMI classification. And that's super important because this is a really big problem, a pandemic, epidemic, you call it whatever you want it. It's tripled, in the last couple decades, and immigrants, especially Filipino Americans, have a higher risk of having obesity. And if you immigrate before the age of 30, you're at even higher risk for being obese. And so, I'm from the Bay Area, California, and Little Manila or the Bay Area, South San Francisco, 7 out of 10 Filipinos are overweight or obese. So that even is higher than the prevalence in the country. And so this is a shout out to thinking about in addition to BMI, which is getting more controversial, it's really important to know where you store your fat. So storing your fat in your abdomen is very dangerous. It's called visceral fat, visceral adiposity. So it's basically fatty infiltration into those internal organs like your kidneys, your liver, having fatty liver, or even around your heart. And so having an increased waist circumference or increased visceral adiposity is associated with metabolic syndrome that includes diabetes, a lot of food-related, obesity-related cancers like colon cancer, breast cancer, and also obviously cardiovascular disease that we need to tell patients to, or we want patients to have more of a pear shape, understanding that this is very genetic, where you store your fat, where you're storing your fat more in your hips is more protective than in your abdomen. And so that's what the shape that we want. We want a pear shape. And so it's important when you look at your patient, in addition to their BMI, is where they store their fat, which is what I'm showing here. And so when I think about diet and nutrition, I think about my favorite patis with sinigang. I think about my mom making mangoes with this bagaong. Please correct me if I say these incorrectly. I think I know my accent is not that great. Sinigang, you have your tosilog, which a lot of us enjoy, which is white rice, pork tocino, and the egg, and there's really not a vegetable or a fruit on that breakfast plate. And then a very highly ultra-processed food group that is very staple in the Filipino diet and even in Hawaii with spam musubi. And so what do all of these have in common? Well, they're high in sodium, that was just discussed, and this is directly associated with high blood pressure and hypertension. Ultra-processed, which I'll touch upon briefly in a bit, that is associated with heart disease, cancer, and overall mortality the more servings you have per day of ultra-processed food. And then having a very high-fat diet is associated with obesity and cardiovascular disease, similar to high cholesterol or hyperlipidemia that was also touched upon. And so what about lechon, adobo, fried rice, garlic fried rice, and pancit, pandesal? All of these are very much comfort foods in the Filipino American diet or the Filipino diet. And we have a very high refined carbohydrate diet that's associated with these very highly prevalent risk factors for cardiovascular disease, like your diabetes and obesity. Ultra processed, again, you get the theme. All of our foods have a theme of being pretty unhealthy and high fat and cholesterol as well. And then I forget what this one's called. Can someone shout out? You eat it with like coconut, right?
Bibingka.
Bibingka, yeah.
Bibingka.
So I live in Middle America now, and there's really no Filipinos, and I'm like forgetting my favorite foods, bibingka. So it's very delicious, right? There's like a salted egg in the middle, high fat, high sugar. My mom makes me this ginatan without all those extra things. I only like the mochi and the little tapioca balls and the langkat and the banana, but everything else I don't love. Everybody loves a halo halo. This is San Srival, right? Okay, San Srival, and my favorite leche flan. And again, Filipino desserts, incredibly high in sugar. This is not what our community should eat. This should be eaten sparingly at very special occasions. And Filipinos love to get together multiple times per year, but this should really be rare occurrence. And it's very difficult to change in our Filipino community. And this is meant just for exposure so that we are all more aware of and identifying bad foods, because it's important to just start the discussion. And so the question is, well, how do we decrease our risks in our Filipino American community, right? So there is a whole triangle of losing weight. We know that if you lose at least 5 to 7% of your body weight, that's associated with a 60% decreased risk of diabetes in a large study. And so basically, if you weigh 160 pounds, 7% of body weight is only about 11.2 pounds. So just keeping that in perspective, sometimes we lose what 5% is and what 7% is. And so talking with your patients or your loved ones or your community about their weight and if they're overweight based on those BMI categories or where they store their fat. This is a picture of Chicago, which I miss dearly, where Dr. Volgman currently is. And it's really important to talk to patients. A lot of patients and your family members, and maybe you yourself, give yourself a pass when you're on vacation. And you eat whatever you want when you're on vacation. You don't work out when you're on vacation, and you let your doctor know or your friends know, well, I was on vacation. When I get back from vacation, I'll be healthier. But that should not be the mindset. We should be integrating ways to be active during vacation, because it makes the rest of your day more active, more light. And so we try to do some type of run or some type of activity as part of your vacation. And the more you develop these small habits that are integrated in your life, the less work it will feel to change these behaviors and these lifestyle modifications to help your risk, which has been said multiple times in the past hour or so. And then our diet, right? And so this was all of the fruits I bought from Makati when I was in the Philippines many years ago at the farmer's market, and I saw jackfruit for the first time. So making sure we get our fruits and vegetables. And so I'll just pivot, for the last couple minutes just to stay on time to leave room for questions about, well, how can we modify a lot of these Filipino comfort meals that we all find home in and comfort foods? And so, our typical morning breakfast, if you love the, toasty log, breakfast, instead of having that whole mound of rice, right? Why don't you tell yourself or your family or patients to cut the portion in half, right? Maybe instead of white rice, you make brown garlic fried rice. Instead of pork or beef for the toasty log, which is very high in saturated fat, and we know that saturated fat is directly proportional to your LDL cholesterol increasing. There are other ways to have that protein with that kind of savory taste. You can saute green beans. So now this breakfast has a serving of vegetables, which is very important to have with every meal, or using chicken or turkey ground meat instead of having this highly saturated fat. And then when we think about our family and ourselves who might have diabetes, thinking about low carb diabetic friendly meals that are low sodium. So depending on how you cook your adobo, you can have a very high sodium intake, which is obviously increases your risk for having elevated blood pressure. So you could find any of these recipes online and look, the only sodium you see on here is this half cup of reduced sodium soy sauce. And so when I think about the nutrition facts for patients, now they're getting ample amounts of protein, over 40 grams per serving. Look at the sugar and carb content is low. Even the saturated fat is pretty reasonable. The sodium, you're not going to really get as low of sodium as you want anytime you use even reduced sodium soy, but this is much better than other options in the diet. When I think about pancit, I think about a lot of carbs, right? Most of it is predominantly those egg noodles or rice noodles or whatever you want with less vegetables. And so, 2 cups has 11 grams of fat, 54 grams of carbohydrates. That's pretty comparable to having a can of soda, which is around 38 to 40 grams, and it has good protein. So how can we modify this, right? Well, has anyone ever tried to use spaghetti squash? It's pretty good. The consistency is not, as chewy, but it feels the same. It has that kind of savory, buttery taste, and you're getting a lot less carbohydrates with the same kind of comfort food as well. And so lastly, with white rice, right? White rice has 46 grams of carbs, 4 grams of protein. White rice is so delicious, even the short grain rice. And so the easier it is to eat and the more delicious, the more you'll have, right? But, thinking about using cauliflower rice. If you can't cut the portion, maybe supplementing the volume with half white rice and half cauliflower rice. Look at the amount of carbs versus the white rice and cauliflower. Or brown rice, there's still a lot of carbohydrates when you look at white rice versus brown rice, but the difference is the amount of fiber. So if anyone wanted to raise their hand and answer, can you eat more white rice in a setting or more brown rice? It's so much easier to eat a high volume of white rice. You're eating more carbs versus eating less brown rice because you're feeling fuller faster from the fiber. And so the other thing I tell my patients are to eat your calories, don't drink this. This is a calamansi margarita. All right, so we have 15 grams of sugar in there. So be mindful about the calories you're intaking from liquids, especially alcoholic beverages are very high in sugar. This juice my mom made growing up, which is like cantaloupe, stringed about with water and a lot of sugar, 47 grams of carbs here we're getting. And that is like, why not eat cantaloupe and get that same sweetness, but you're eating a lot less sugar. And then lastly, as I already said, alcohol is riddled with carbohydrates. And so if you're struggling with obesity, if you're struggling with weight loss, if you're struggling with high triglycerides, think about the amount of alcohol you're consuming as well. Lastly, the most important thing, if I can leave you with anything, is the era of ultra processed foods. Ultra processed foods basically they're defined as having no real food in them. It's through a NOVA classification system. So a NOVA 4 classification defines an ultra processed food. And that basically is saying that there's no real food content in it. It's synthesized in a laboratory. It basically has a ton of preservatives, a ton of artificial sweeteners, artificial things that really have been correlated with poor health outcomes. And really strikingly, over almost 60% of our energy in the American diet comes from ultra processed foods. And as I already stated, they contain no minimal whole foods. There was a study from the Framingham Offspring study. If you Google Framingham, it's a huge cohort that has followed Americans over decades, and they look at the offspring, and they found that on average, the average adult is intaking 7.5 servings per day of an ultra processed foods at baseline. And they looked at them about 10 years later, and they found that each additional serving on top of the 7.5 servings per day was associated with a 5 to 9% increased risk in overall cardiovascular disease and mortality. So that is very worrisome in the explosion of our convenience culture post-pandemic and what we have access to in our neighborhoods. And it really depends on where you're born, what access you have to resources, and your socioeconomic status. So a lot of work needs to be done when it comes to the environment and the infrastructure for how food is presented to us. And so lastly, really the guidelines are based on the circulation guidelines for dietary habits is adjusting your energy and expenditure, so calories in and calories out, to maintain a healthy body weight, regardless of where you're eating your food, if it's out with friends, if you're at this huge airport in Rochester. It's very small, but I say that because people give themselves a pass when they're at the airport to eat whatever they want, and we really shouldn't be doing that. Whether you're having a bad day or you're stressed at home, thinking about what you're eating and being mindful. And really, we want to do everything in green, and we want to avoid and limit the things in red. So you can put in the Mediterranean diet, a Japanese diet, a healthy Filipino diet, depending on what access to food and what is local to your neighborhood, really keeping in mind in green that those fruits and vegetables, minimizing processed foods, plant proteins, healthy plant oils. So thinking about, in addition to, extra virgin olive oil, soybean, corn, safflower, sunflower, flax oil, canola oil, avocado oil, all of these other oils, they're not as popular as the extra virgin olive oil, but they can be a little bit cheaper and more affordable for your patients and for your family. And avoiding everything in red, right? Processed meats, for those of you who don't know, in addition to Spam, it's any meat that is smoked, cured, salting, or any addition of chemical preservatives like nitrates and sodium that have been linked to really bad health outcomes, and really minimizing the amount of alcohol. Currently, the guidelines haven't changed, and for 2 drinks or less per day for men and 1 drink or less per day for women. But more and more research prospectively is coming out that any amount of alcohol is bad. But in our food culture and quality of life, I don't think alcohol is going to be going anywhere soon, but really trying to minimize that as well. So this is just my summary: just to eat less animal meat, eat less foods rich in salt, eat more vegetables and whole grains. And if you're not ready to do any of the above, try to cut your portion sizes, eat your calories, don't drink them, move more and take the stairs, sleep well, and socialize and motivate one another. And that's all I have. Thank you.
Thank you, Dr. Lara-Breitinger, for sharing all those helpful tips and modifications to have a more heart-healthy diet. And now we will open the floor to the community for around 5 minutes of questions. You can feel free to raise your hand or send a question in the chat.
Before we have any questions, I just want to thank my colleagues from the obesity study participants, from Dr. Sanchez Johnson, who is here from Hawaii. Lisa, maybe you can unmute and tell everybody about what we're doing with our obesity study.
Sure. Thank you so much. That was a wonderful presentation. I don't know what's going on with my camera here. Let me see if I can get myself on. Oh,
There you
there I
go.
am.
There you
Yeah,
go.
good. Yes. Yeah, wonderful job, everyone. So I am physically now at the Medical College of Wisconsin, been doing a research study in collaboration with Dr. Volgman, and we have a number of Filipino research scholars that are focusing on this Filipino health study. They don't have to be Filipino to be a scholar, but what we're doing is we are examining cultural variables underlying race and ethnicity as it relates to diet, physical activity, and body image, and also exploring other variables such as skin color, discrimination, and various social determinants of health. And we're going to be using all that data as a pilot study in Chicago, but hopefully rolling it out to Hawaii and other places, across the United States if we get more funding. And so really excited about this. I want to give a shout out to all the scholars that are on this call, Jacob Bless, Irma Rodas, Nicole Aniceto, David Cedillo, and I think Angela, is she there? Not sure if Angela Rose David, David Cedillo. I think I got everyone.
I think so.
Yes,
Yeah.
okay. Thank you so much for being
Thank
here.
you, Lisa.
Really appreciate it. Great presentation, everyone.
Thank you. Rihanna, do you want to ask the question? There's a question in the chat.
Yeah, so it looks like Shen asked a question about strategies you have found helpful when speaking to older patients about heart health. She said it can be particularly challenging to talk to Lolas and Lolos who are set in habits and have a bahala na attitude. And that's anyone for their thoughts.
I echo that attitude. We see it all the time among Filipinos and among our families, and attitudes such as comments like, I would say it in Filipino, mamamatay ka rin lamang ba, enjoyin mo na yung pagkain. So you will die anyway, so enjoy what you want to eat. So that's one. And I actually asked one of my patients who was the daughter of Goldilocks. I said, why is Goldilocks food always floating with fat and also very sweet? And very salty, and they said that they tried to reduce all those contents for health, but it didn't sell. People didn't want it. They didn't buy it. And of course they are a business, right? So they brought that back. So in the Philippines, the same thing. When you can't taste the salt, it says it's very bland, hindi masarap. In where I come from, in Pampanga, which is the chef capital of the Philippines, we all have those high carbohydrates. Almost all the bibingka, the kalamay, the ginataan, the everything is there. And so we all also have obesity and diabetes and hypertension, etc. So how could we improve that when the attitude of the people doesn't really align with our messaging? So that will be a question to you, Kyla.
Sure. So I get this all the time with my own Lola and aunties. And what I think is super important is to acknowledge that, you know what, you're right. You come from the Philippines, where having access to an abundance of food and too much food was a sign of security and a sign of wealth. And so in America, though, that has switched around to having too much, and the bigger you are, you're more associated with lower socioeconomic status due to the quality of the foods. And so I feel that when I talk to them, I say, well, what do you enjoy about it? And Filipinos go to a party and they eat right when they get there, then they sit down for about 20 to 40 minutes, and then they say everyone get up and get more, and then you keep going, like, and you graze or not even graze over 8 hours of being together, and maybe a couple people are dancing and doing karaoke, but everyone is so sedentary. And so I think it starts with education. I care about you. I love you, Lola. You live in 2024 where you have access to valves that can be put in you when you're 90 years old. There might be 3D printing of organs in 10 years. We have access to newer medications that can make us live longer, better. We have to keep ourselves as healthy as possible, because if you lived in the Philippines, living to 60 or 70 might be great enough while having some nutrient deficiencies. But here we have the opportunity to live longer for healthier. And so you could still enjoy the foods, but let's eat a portion of it, and let me make you an alternative, and you could eat half of what you normally eat, and then you could eat half of what I want you to eat, or you'll have 2 glasses of water in between meals, and you could reassess if you're actually hungry. So I'm very persistent with my own family, and I did a master's in nutrition before thinking of becoming a doctor, because so upset by everything my family was eating. And I thought, well, if I become a doctor, or if I do this nutrition master's, they'll listen, and they still don't. So it's an ongoing battle. So I don't stop trying.
Great.
Same thing here. Same thing with me. You know, like we're 10 in our family. 8 of which succumbed to hypertension, diabetes, and so there were 10 of us, and now there are only 4 of us. And so it's so personal to me, and it doesn't really matter what you say. They will still do whatever they want to do. And most of my patients are like that too. And food is one of the hardest thing to change besides alcohol and drugs and smoking. So I think, yeah, I think it might be nicer to, like for us, what we do is then be more active, right? So Filipinos love to dance. So maybe that will be another thing, you know, love to dance. And if you notice, though, people don't care about their weight, about how they look. It's less so. And among nurses, if you see, like you go into the hospital, what do you see at nighttime? All the nurses take out all the food that they brought, and they eat all night long. I remembered when I was a nurse, I gained so much weight working at nighttime, because that's what we did, is eat all night long. So I mean, it's really like, it's one of those things that is still, you know, like bothers me. Like, what are we, how do we say this? How do we message our patients? And in the Philippines also, good food, vegetables are more expensive now. Processed food is less expensive. It's also true in the US. Processed food, fast food is less expensive. So a lot of the younger people just kind of like, you know, use that rather than cook, right? If you try to cook, by the time that you have all of these ingredients, it costs a lot more money than if you just bought an In-N-Out burger or something. So, yeah.
We are running a little bit past 7, so I do want to be respectful of panelists' time. If any attendees had questions that were not answered, I will send an email in the chat, and you can reach out to that contact. But really just maraming salamat, Dr. Santos Volgman, Dr. Gabiola, Dr. Lara-Breitinger, for sharing your time, your insights, your expertise, for building community with us tonight.
Thank
Thank
you.
you for
Thank you,
inviting us, and thank you
salamat.
everyone for coming. Thank you.
Thank you. I love your presentation, Kyla and Annabelle. Yeah.
Cool
Thank
job.
you.
So great to be next to you both. Love you, Dr.
I love you, Kyla. And Julieta definitely says the Filipino foods better than Kyla. I can't believe that you don't know these words, Kyla. You grew up among
I made chicken sinigang the other day.
them.
Half the packet of mamacita. So
Yeah, I know. I shouldn't even